again have this as a nice collaborative event. And I'm going to pass the mic off to Dr. Staines.
All right. Hello. Good evening. I'll be here all week. Hey, I'm Mark Staines, one of the cardiologists here in Greensboro. First off, thank you to Kelly, THN for organizing this event. Wonderful food, fellowship, and hope y'all enjoy the high sensitivity troponin part of it too. So, just as a little overview, I'm going to talk a little bit, give a good general, this is a good general overview of the rationale behind this project, and we're going to have a journal review by Dr. Nanavati as well, that we're going to skip over to midway through. And then we also have the pleasure of having Dr. Gibson here as well, who's with the empathic team that a lot of the ER probably already somewhat familiar with. And he's going to give us a little demonstration on their program. And for those of y'all that have no idea what I'm talking about, we'll learn about that as we move forward here. So, let's go ahead and get started here. First thing I wanted to bring to everyone's attention, if y'all were not aware, there's actually a new APGAR T-score to check troponins 1 and 5 minutes after birth. This is out of DC. The ACOG basically is modifying the APGAR score to the APGAR T-score, which troponins will be checked on every newborn infant 1 and 5 minutes after birth. This is bad news for babies, as the likelihood of negative troponins is left next to nil due to the sensitivity of the chest. So it'll make it that much harder for babies to get a perfect score. And by adding this 1 and 5 minute troponin after birth, it will ensure that babies become quickly acclimated to what will become a lifetime of unnecessary troponin testing. Just wanted to throw that out there. That is completely bogus. Okay, guys? Thank you. Dr. Reed, of course. So why make this transition to high sensitivity troponins? Couple big picture items here. So number one, the HS troponin improves the diagnostic accuracy of acute MI. And the way it does this is it can detect small changes or deltas in the troponin in a very short time frame. And what this allows for is these accelerated diagnostic protocols, or ADPs, that a lot of ERs are going to be using, which leads to a faster, more confident discharge, certainly of low-risk chest pain from the ER. And we're going to do this in collaboration with this tool that's going to be integrated with Epic, that we're really excited about, called the empathic tool. And that's where Dr. Gibson's going to give us a little demo a little bit later on in the presentation about this. So, some steps in the preparation here. We've been meeting now for about 9 months or so as a multidisciplinary team comprised of ER physicians, hospitalists, cardiologists, pathologists, IT, cafeteria workers. We have them all basically have been meeting on a routine basis. And our pathology team basically has been validating the assay, and they have to do this for basically 90 days prior to the initiation of this assay, this new assay. Our potential go-live date, or our projected go-live date, is in the end of March, the end of March of this year. I think it's perhaps March 27th. You should correct me. 27th. Thank you. Correct me if I'm wrong. Of course, the lab team knows this. And other steps in preparations, we've developed some new chest pain pathways, some new protocols that we'll go through a little bit, and also implementing this empathic program, collaborating with Scott and his team, which has been awesome. And then, of course, there's the education process that we're going to be in this part of it tonight. So, co-health system-wide adoption. Basically, high sensitivity troponins will be utilized across the entire cone health system, okay? And like I said, it'll start in the last week of March of 2020. and other troponin assays, which include the point of care troponins, as we have currently, and our troponin I that we're currently using, those will go away. Those will be discontinued on that start date. So we won't have any period of time where we'll have some of our old assay running with the new assay, or some point of cares that will be running with the new assay. And this is basically, we're going to use one troponin assay just to minimize confusion across the board. So one of the biggest things about this whole work group with the high sensitivity troponins is we're going to take a big step back and really evaluate our order sets with troponins. And right now in current state, there's over 50 order sets with troponin embedded within them. And some are pre-checked, like in STEMI, or some are not pre-checked. But there are over 50 right now that are out there. And this work group, we've eliminated the troponin choice in several of these order sets. For instance, the sepsis protocol, whether it's in the ER or on the floor, we decided to eliminate the troponin from that order set so that we don't routinely check troponins in that setting. I'm not saying you can't check troponins in the setting of sepsis, but we have to be thoughtful about when we're checking troponins, basically. And at the bottom there, remember, this high sensitivity troponin should be utilized when there is suspicion of ACS. Okay, so that's super important, and it's going to be beaten down on us over and over and over again. So this, the reporting. So the values, these new troponin values will be reported out as integers in nanograms per liter. They're all going to be whole numbers. So Kevin Campos can understand it's no longer 0.03, 0.04. They're very challenging, Kevin. So these are going to be whole numbers. And for instance, the 99th percentile cutoff, just so we know, is going to be 18. 18 will be sort of like our 0.03 that we have right now. So 18, so we don't all start to freak out when we see all these larger numbers that we're all going to see. We're not going to use sex-specific cutoffs. Some institutions, or some recommendations out there are to use both female and male specific troponin values, i.e. the Beckman assay that we're going to be using here. There's a 15 cutoff for women, and there's a 20 cutoff for men. And we've decided to basically bring that down to 18. Almost kind of middle of the road so that there's no gender-specific cutoffs. And I think that's going to allow for clearer, safer interpretation and to try to minimize a lot of confusion out there by adding the female or the male-specific cutoffs. But some institutions do utilize that. Of course, the lab turnaround time will be less than 60 minutes, like we expect for all of our lab values. And Dr. Kish and those guys are awesome and virtually guarantee that that'll be delivered in less than 60 minutes, or the next pizza is it's like Domino's. I think they'll come up and give you an extra. Just to show you, this slide is just a representation of the cardiac troponin concentrations there on the y-axis, and you can see there are these limit of Planck, limit of detection, limit of quantification, and then you have your 99th percentile. And the reason I put this up here is that the limit of detection is about 2 for this Beckman assay, and our 99th percentile is going to be about 18. So there's going to be a fair number of people out there that may have a troponin of 3, or a troponin of 7, or of 12, and they're perfectly healthy individuals with that troponin. And as we evolve and continue to move forward with what do we do with that certain population, and there's a lot of debate out there for that, but these people are healthy, they're normal. It's just that 70% of us right now have a detectable troponin in our bloodstream. So more to come on all that as we continue to learn. So the assays here, this is just a table showing a couple of the different companies out there. We decided to choose the Beckman assay. That's the second on the top line there. There's that limit of detection of 2.1, and then the 99 percentile of 18 when it's combined between male and female. There they have 12 and 20 as male and female. So essentially, we're going to be utilizing this Beckman protocol. With the high sensitivity troponins, like I was saying, some of the values here is that we're going to have a quicker detection of this HS troponin, a quicker delta on the troponin, meaning if we order it at time 0 and then we order it at 2 hours, we're going to see a meaningful change in that troponin. So there are a lot of troponin-only protocols that have been validated out there that are being used in Europe. For instance, there's a 0 to 3 hour, there's a 0 to 2 hour, there's a 0 to 1 hour troponin protocol. And we decided to go ahead and move forward with a 0 to 2 hour protocol here in our emergency department. And utilizing this half program, we're going to really be able to help streamline that process pretty well. And I can't wait for that little demonstration to basically show us some more things. So right now what I'd like to do is just pass the mic over to Dr. Nanavati. He's going to talk about the journal article that you have in front of you right now. And just in general, one other reason why we're moving in this direction is globally, we're using more and more high-sensitivity troponins. In Europe, it's sort of the standard of care right now, and more institutions here in the States are utilizing it. A lot of our friends down the road are already utilizing it. And I guess we feel like, if we don't go ahead and get started with this, at some point, we're all going to be using it. We might as well jump in now and learn as we go and evolve as we go. So, and luckily, we do have some colleagues here in our heart care division that have experienced the transition to HS troponin. Dr. Christopher, for instance, from Duke, recently experienced it. So we're going to gain a lot of wisdom from them and help us evolve through this process. So, Dr. Nanavati.
Good evening, everyone. So if you don't mind, maybe drawing your attention to the article that talks about high sensitivity troponin and an algorithm that uses a hard score. We decided to use this article because, just like us, this institution in Sweden, it appears that they knew they were going to transition to high sensitivity troponin, and they wanted to know if the transition to high sensitivity troponin gives them an opportunity to look at their current process and see if it enhances their algorithm at identifying ACS. And really that's important because chest pain is not going away. These are the facts on chest pain. About 7.5 million out of 145 ER visits are for chest pains. And I looked at our Moses Cohen health system. So system-wide, our data shows that 13,000 patients in 2019 out of 295,000 total, roughly 4.5%, mentioned chest pain. Didn't even mention shortness of breath, or some of the other non-specific complaints that can present as ACS. This is just chest pain. So these patients are going to continue to come regardless of what assay they're using. According to one of the prominent malpractice law firms, about 1.5 and 7 million people who visit ED with chest pain end up having ACS. And the statistics show, including an article from the New England Journal of Medicine, that the miss rate could be as high as 2 to 5%. So heart attack and a misdiagnosis has a high mortality and morbidity index to it. So it's consistently one of the top reasons for malpractice against ED physicians. These are just facts in the world we live in. And so we were very judicious about the rollout of high sensitivity troponin when that opportunity came up. So let's talk about the study. The research trial, what they set out to look for was the impact of a combination of high sensitivity troponin and an algorithm that had heart score, with the primary outcome being admission rate. So that was the primary outcome they were looking for, and the study was powered to look for a difference in that. The secondary outcomes that they were measuring were time to discharge of the patients, healthcare-related costs, and the 30-day clinical outcomes. The study itself was a prospective observational trial that was multi-center, with 6 centers were enrolled in Sweden, and it was conducted over 2 phases. Phase 1 was pre-implementation of the algorithm, and so that was from June 2013 to September 2014. And phase 2 was after the implementation of the pathway, the algorithm, and that was from January 2015 to May 2016. The inclusion criteria was all patients that came in with chest pain, where there was a reasonable suspicion of ACS, and they were age over 18. The duration of symptoms had to be more than 10 minutes, and the onset of their symptoms had to be less than 12 hours. This is in Sweden. Quality of life matters, so only the patients that presented during business hours were enrolled in the study. We talked about the 2 phases. So phase 1 and phase 2. Phase 1 was the traditional way of diagnosing ACS or attempting to rule out ACS, which was the clinical assessment of the patient, followed by EKG, and then getting serial troponin. So over there, they were getting troponins at 0, 3, and 9 hours. So that was their traditional way of ruling out ACS. Phase 2 was completely different, right? So now they wanted to assess patients using a new protocol, and that involved a 1-hour high sensitivity troponin, and they used heart score for risk stratification of the patients. Now, some of the sites were using troponin T assay, others were using troponin high assay, but in general, all of them switched to high sensitivity troponin. The absolute level cutoffs and the delta cutoffs were provided by the respective manufacturer, and then for high sensitivity TNI troponin, they used gender-specific cutoffs for their algorithm. Now, emergency department physician could overrule the recommendations of the cutoffs if clinically indicated or if they thought was necessary. This is the algorithm they had again. This was a protocol. I want to preface again that this looks nothing like our protocol. But to highlight their protocol, every patient that showed up with chest pain and there was concern for ACS, they would get high sensitivity troponin drawn at hour 0 along with calculation of their heart score, and that at 1 hour they would get a repeat troponin. If the initial troponin was less than 14 or less than the other cutoffs for the other assay, and then the deltas were also below the thresholds that were provided, they then looked at the heart score. The heart score was less than 3, then these patients are highly unlikely to have ACS, and they were effectively ruled out from ACS and discharged. Now, if the cutoffs were, the patient's troponin levels were below the cutoffs, but their heart score was greater than 4, then these patients, by definition, are going to be still at an elevated risk of having ACS, and so some of them were considered for admission, other patients were discharged. If the scores were higher than the cutoffs, then they were essentially admitted for further workup. Now, patients who came in with really high sensitivity troponin at the offset, they did not change their approach to those patients. So those patients were pretty much akin to our patients who come in and have a troponin of 0.28 or 0.3 right now. Some of them we call cardiology team, others we don't. So I think that's what they did over there. They really didn't discuss what their approach was on those patients. Study characteristics. Well, the baseline characteristics for the patients were pretty similar. The demographics were same as far as age and gender is concerned. The risk factors were also very similar. There were some changes on the previous cardiovascular disease aspect. So more patients in phase 1 had angina pectoris as a diagnosis. More patients in phase 1 also had history of PCI or CABG. And then there were also higher volume of patients who had known peripheral arterial disease. So that's just something they noted. about 500 plus patients, so more than 90% of patients initial EKG were completely normal, and the time of onset for chest pain was close to 3 hours for both phases. So in total, there were about 1,233 people that were enrolled for the study. Again, there were 2 cohorts. There were very similar demographics and risk factors on both ends. The differences in baseline characteristics were adjusted using different statistical tools. And the incidence of MI post-admission, so these were the people who were ruled in after they were admitted, was similar, 23% in phase 1, 22% in phase 2. Initial troponin was normal in about 460 patients and 476 in each trial. So about 75% of the patients that came in had normal troponin, even when they switched to high sensitivity troponin. And that's good. That tells us that if you use the troponin judiciously and in the right patients, you really should not get a lot of false positives. And then they looked at the total length of stay for the patients. And the patients who were in the ER, their length of stay went down. The patients who were admitted, their length of stay also went down. And the adherence to the algorithm was about 87%. So there were 39 patients who were deemed as low risk based on the algorithm, but they were still not discharged. They did not give any explanation on why those patients were admitted, nor was there any discussion on what the eventual outcome was on those patients. So the outcomes. Again, the primary outcome that these researchers came to study was the admission rate. And as you can see up on this table, the admission rate went down from 59% in phase 1 to 33% in phase 2. So that was a pretty significant difference between the 2 trials. As the number of patients that get admitted go down, also with the length of stay. So the total length of stay was 23.2 hours for every patient that came in with chest pain to the ER in phase 1, and that went down to 4.7 hours in phase 2. Finally, there was also healthcare-related costs that they were calculating, and that cost also went down because, again, admission probably has a higher chunk of cost that comes with it, and so that value also went down. On the flip side, and I think a lot of us are interested on the clinical outcomes, the readmission to the hospital. We discharging too many and they're going to come back. Well, that was not something they noticed in their study. 44 patients came in for readmission, 36 in phase 2, so lower again. Myocardial infarction after discharge was equal in both algorithms, or both phases. And then death after discharge was nil in phase 2. There were 2 people who died in the other. So in general, their findings were very positive. They accomplished, what the study accomplished, what they were looking for, what their hypothesis was that the admission will go down. And then the secondary outcomes that they were also measuring, what it would do. So again, reduce admission, reduce length of stay, both in the ER and the patients who were admitted, reduce cost for the healthcare organization. And then also, I'm sorry I forgot to put this slide, but this is in table 3. There were reduced non-invasive testing both in the outpatient and the inpatient setting. And I think this is what the cardiology group is looking at. If the troponins continue to be negative, they would have the ability to say, I don't think we need to even do any non-invasive testing in some of these patients. So I think the cardiology team here, they could probably look at table 3, and they will see that all non-invasive testing, all kinds of stress testing, pretty much went down except for the new testing. And all of that was done without any change in the 30-day clinical outcome for the patients. So here are some of the limitations. Well, the study was not randomized, and the recruitment rate was low. So both of this means that there's going to be some accidental bias that's going to be introduced. There will be some selection bias because it was phase 1 and phase 2. The study was powered to show reduction in admission and not clinical outcomes, so we should not really jump to any conclusion on clinical outcomes based on this study. And there was no discussion on how patients with known coronary artery disease were approached. So if you look at the demographics, I think I again mentioned there were higher amount of people with known CAD in phase 1 compared to phase 2. They really didn't discuss, well, what was the impact or how their algorithm performed for patients who had known coronary artery disease. And then there was also no discussion on why there was reduction in non-invasive testing. So I'm just making my own postulation is that maybe the troponin stayed negative, and because it's a high sensitivity troponin, cardiology teams felt empowered to say, yeah, we're not going to do nothing. So overall, the study was fairly good. I think we used it because we are in a similar predicament with the empathic tool. We also want to measure some of our patient demographics, the risk factors, and see if we can augment our process that we have right now. And once we roll this out, we can augment the process even further. So that's all from the discussion or the article. Any questions about the article? Thanks.
Dr. Navali. I think we can all be excited about the potential of reducing observations, of reducing admissions, certainly reducing imaging costs, improving patient throughput. The study certainly sounds almost too good to be true, and hopefully we do have similar findings here at home once we get this enacted. So going back to, I want to give you some examples of what high sensitivity troponin values might look like in the future here. If you look down here, healthy individuals, once again, they may have a troponin of 5 or so. They may have a troponin of 3. They may have a troponin of 7. They're healthy. Their negative predictive value for MI is greater than 99%. We may, as we move up past the 99th percentile, which once again will be at 18, we start to see the different variants of values here. And as we go higher in the troponin value, there's higher positive predictive value for myocardial infarction. So a large STEMI, for instance, an inferior and anterior STEMI, might have a troponin value of 50,000. And that's pretty obvious. That's going to be an MI. And we'll still be faced with elevated troponins with myocarditis or PEs, heart failure, shock, hypertensive crisis. So once again, this is going to be where we have to be careful and thoughtful about when we're ordering this high sensitivity troponin test. We want to order it when we were suspicious for acute coronary syndrome. And here's some cone-led clinical conversions that Josh Kish and his team were able to look at. We looked at about maybe 50 or 60 or so. I know many more than that, but on this spreadsheet that was provided to us, and here's some common values that were noteworthy. So the old troponins on the left that we're currently using, and the new high sensitivity troponin is in the middle. And here's some clinical scenarios that go along with those troponin values. So, for instance, if someone came in with atypical chest pain at 0.01, the new troponin was 8. They had a diagnosis of chest pain, obviously less than the 99th percentile there. There was a acute systolic heart failure of 0.13, and the new troponin value was 141 in that setting. So 0.13, 141. You kind of see, one of the correlations we kind of noted there was if you move the decimal over 3 spots, you kind of get a feel for where the old troponin was or where the new troponin will be. AFib with RVR, got a troponin of 0.33 in that situation. It was about 310 on the new troponin, all in integers once again. Sepsis, 1.6 old, 1,459. We'll move the decimal point over. A non-STEMI with a troponin of 12 or 13, and it was about 9,000, okay? And then a STEMI, this was an inferior STEMI, 52, current troponin was 52,000 on the new assay. So if you move the decimal spot over, maybe 3 spots, you can kind of get a good sense as we're transitioning, as we make that transition at the end of March, to go, okay, where was this in the old troponin days? And just kind of keep that in the back of your minds. I thought that was helpful. But what this chart illustrates is that there are several different clinical conditions that will elevate the troponin, and unfortunately, the high sensitivity assay does not get rid of those elevated troponins like we see in chronic kidney disease, or like we see with acute systolic heart failure, or with a contusion after a car accident, or any number of conditions. So this table here, and which you can't see, type 1 myocardial, there are 5 different types of myocardial infarctions, believe it or not, according to the 4th definition. And this was just to illustrate type 1 is what we call our non-STEMIs and our STEMIs as of right now. Those are spontaneous myocardial infarctions that are related to plaque rupture, fissuring, erosion, dissection, results in intraluminal thrombus of one or more coronary arteries. These are typical heart attacks. That's a type 1 MI. Where the confusion sort of comes into play a little bit is this type 2 MI, which is the second one on there. It's myocardial infarction secondary to an ischemic imbalance. This is the term that we've been using here more so of demand ischemia. So this is just a supply-demand mismatch. In other words, severely hypotensive in the setting of sepsis. There's a supply-demand mismatch, and that person will have an elevated high-sensitivity troponin, and this is secondary to demand ischemia. And we as an institution, we're avoiding that term type 2 MI because it leads to a lot of confusion for the patients. They think that they all have had our typical type 1 heart attacks in that situation. It also leads to some changes in their DRG, their hospitalization. In other words, if you come in with pneumonia or AFib and you have a slightly elevated troponin and someone calls that a type 2 MI, that pneumonia gets trumped by a type 2 MI diagnosis, and that patient becomes labeled as an acute MI in the DRG, which has lots of ramifications down the road for not only that patient, from insurance companies, whatever, but for an institution as well. If that patient gets readmitted, now they're readmitted with an infarct. Or the post-op cholecystectomy patient that comes in with AFib RVR a couple days post-op, and someone checks a troponin without chest pain or whatever, they just had AFib, and their troponin's elevated, that was called an MI, that all of a sudden is a post-op MI, and there's a lot of ramifications there. So just want to encourage everyone to use that term demand ischemia in that setting. Type 3, just for your notification, is myocardial infarction resulting in death when the biomarker values are unavailable. So these are cardiac arrest patients that come in, our hypothermic patients, for instance, protocol patients. Type 4 are after PCI or after any sort of percutaneous intervention, and then type 5 is an MI after a bypass. So from the article from the 4th definition of myocardial infarction, these are the criteria here. So the term acute myocardial infarction should be used when there is acute myocardial injury with clinical evidence of acute myocardial ischemia with the detection of a rise and or fall in troponin values with at least one value above the 99th percentile, and at least one of the following. They need to have symptoms of myocardial ischemia. This is super important. You need to have that suspicion for myocardial ischemia present. They need to have new ischemic EKG changes, or at least one of the following. Developmental new Q waves. Maybe there's some imaging that shows a hypokinetic segment on their echocardiogram, or loss of viability on an MRI, or nuclear stress, for instance. Or there's identification of a thrombus by angiography, which is essentially our type 1 MIs. And just to hammer down the points again, some common examples of non-ACS, high sensory troponin elevation, sepsis, severe anemia, pulmonary embolism, heart failure, renal failure, chronic kidney disease. As we all see, they can lead to these chronically elevated troponin values and myocarditis, tachyarrhythmias. There's that supply-demand mismatch. Anybody post-ablation, anybody that's hypertensive, Takotsubo, stress-induced cardiomyopathy we see. And over on the right there, this is why it's critically important to order this test in a proper clinical context. And I think we've all grown accustomed to, we just don't blanketly order, for instance, a D-dimer on everybody, just with a suspicion of PE for that matter. I mean, it could be positive in the setting of other reasons for inflammation. We have to be thoughtful about when we're ordering this study. But I want to make this point clear too, that we should avoid the term sort of troponinemia or, oh, it's just a little leak, it doesn't mean anything. Because even if the troponin elevation is present, it does portend a worsened prognosis overall. And this is a little graph that demonstrates that. At the bottom, that bottom line there is a troponin less than 5. And then the top line is a troponin greater than 50. These are all troponins. And you can see their cause of all-cause mortality over 4 to 5 to 6 years. Definitely it's higher if you have an elevated troponin for whatever reason. And certainly those septic patients with a troponin elevation, they're sick. They have a much higher or worsened prognosis over 30 days and for that matter over 5 to 6 years. So once again, this type 2 MI, this is a supply-demand mismatch. Please, when we're, quote, labeling or diagnosing these patients, we like to use that term demand ischemia in these situations of supply-demand mismatch. And it avoids the confusion, the mislabeling, the DRG, and these cascades that can lead to potential sort of unnecessary testing because they're confused with a type 1 MI in that situation. There's another term that we should be familiar with. It's called myocardial injury secondary to blank. For instance, if ischemia is absent, and their troponin is positive but flat, consider that phrase, myocardial injury secondary to pericarditis, or secondary to contusion, or CKD, or LVH, or stroke, for that matter. So that's another term that potentially we should begin to utilize a little bit more. And this graph, just based on where this table demonstrates exactly what I was just talking about. With all the way on the left, that's a type 1 MI trigger. All in the middle there, type 2 MI examples of severe hypertension, tachyarrhythmias that are sustained. Try to use the term demand ischemia in that setting. And then all the way on the right, there could be chronic myocardial injury in the setting of structural heart disease or chronic kidney disease. And that may be a time where we document, instead of demand ischemia, maybe we document myocardial injury, that troponin secondary to chronic kidney disease for that matter. So a couple little take-home points here for high sensitivity troponin. It's going to be a faster, hopefully, lead to a faster, more confident discharge from the emergency department in those low-risk patients. It will lead to increasing false positives, okay, because it's more sensitive, and false positive for possible ACS, so we have to be careful. And do not order this test unless there's real clinical concern for ACS or non-STEMI. And then, of course, document the reason for that elevated troponin, whether that's STEMI or non-STEMI, demand ischemia, myocardial injury. Let me talk a little bit about this accelerated chest pain protocol, and then we're going to have Dr. Gibson come up and speak to the empathic pathway. So we collaborated with Dr. Simon Mahler over at Wake Forest and Dr. Gibson. Dr. Mahler here, he was on the JACC scientific expert panel with other institutions like Duke, Kristen Newby, for instance, that came out with one of the articles that you have in front of you today that are sort of helping other institutions throughout the world go ahead and proceed with high sensitivity troponin. He's a professor of emergency medicine at Wake Forest. This program, Empathic, developed a heart pathway. Scott probably can talk a little bit more about that, but it combines a decision aid with serial troponin measures to achieve greater than 99% sensitivity for major adverse cardiac events, or MACE, at 30 days, or early discharge rates up to 20%. So the heart pathway, it does differentiate itself from the heart score by asking some specific historic questions that can be less subjective and more reproducible across providers. And one of the things here in red here, there is a heart pathway app that you can download from the Apple Store and put it on your phone just so that you have those questions handy. And it's a free app, you can utilize it anytime. It might be good for us as the cardiologist to remember what these questions are through the Empathic tool, to have that handy on your phone. And this pathway is going to be embedded directly into Epic, which is a great sort of novel way of combining Epic with an add-on tool that sort of seamlessly integrates. And it's going to assist in auto-generating an emergency room note on that chest pain patient. It's going to pull in the high sensitivity troponin values automatically, and then it'll put us through a protocol, and it'll help provide some disposition suggestions to the providers as well. And the cool thing is these algorithms can be adjusted as we evolve or as we see fit. And we're really excited about the new tool and utilizing it. So I think at this point I was going to ask Dr. Gibson to come on up here and talk a little bit about the Empathic tool.
Thank you very much, Dr. Steens. As you were saying, actually, Scott Gilmore.
Oh, that's a good.
It's okay. I just go by Scott. No one knows me Scott.
He's also highly sensitive.
Yeah. Much like the troponin we're discussing today. So yeah, I'm Scott Gilmore. I started Empathic with a couple of my mentors at Wake Forest, basically with the vision that we could do so much more with the EMR that we're doing right now clinically. It does a lot of things well, it manages orders well, you know, it keeps everything on track. But when it comes to my shifts, I'm an emergency physician, it could be helping a lot more. And when we reached this problem of high sensitivity troponin, we realized this is really complicated. We're having to calculate changes from one troponin to another, and anytime I'm doing math on my shifts, in my head, it's a bad thing. And we want to keep things simple for providers. And it just so happens that when we were having these ideas about people want to make the medical record better, lo and behold, Epic and Cerner and other EMRs developed app stores, kind of like on your smartphone, where you can develop these clinical applications and then share them between different institutions to accomplish something clinically. And so we started putting the heart pathway on the Epic App Orchard, and that's evolved to the tool that we're now able to offer. And let me make that full screen so you guys can see it better. So you can think what we're doing is it's kind of like we're taking MD-Cal, which almost everybody uses in their practice now, which is a web-based tool for clinical decision support. And we're taking a lot of that simplicity and functionality and bringing it into the medical record and empowering it with the medical record's ability to move information about the patient into the algorithm itself, as well as track how the algorithms are used or how the tools are used over time. And like Dr. Steens was saying, enable us to adjust protocols, adjust how we're doing medicine over time. And so that's really the vision for what we're doing overall. And I'd like to tell you more about, the reason we've really focused on this chest pain thing is, as you know, there's 5,000 emergency departments across the United States, 8 million chest pain visits, and more than 50% of those chest pain visits on average, the average institution are admitted. And only 10% have ACS. So in the United States, we have a huge problem with over-admission of chest pain presentations, leading to about $13 billion in chest pain evaluations, which is incredible. And even though we're doing all of this testing, all these categorizations, all these stress tests, we're still missing up to 4% of instances that come through the emergency department. So the heart pathway that we were alluding to earlier, you can download on your smartphone, was an effort to take specific clinical criteria and develop the best possible risk stratification algorithm that can separate out the patients who are really sick from the patients who are not as sick and can go to the outpatient setting and get routine cardiac care. So I'll skip some of these slides. There's a lot of stuff you can find online about the heart pathway, a couple of key differences from the heart score, but I want to jump in to the interface that the emergency physicians will be seeing. This is what the application looks like. It's embedded directly in the Epic EMR. It's launched when a provider orders one of the new high-sensitivity troponin assays. And the provider answers a few simple answer questions about the presentation that can all be tracked. And, this is the lab order. This is the PPA that launches, encourages the provider to use the heart pathway tool. A key element of high-sensitivity troponin is the time when the symptoms started, because as we know, it can take some time for the troponin to rise. So if we're wanting to use the assay to its full ability, we want to take advantage of those very low values. Say, wow, this value is very, very low. This patient is at very low risk for ACS. But to draw that conclusion, you have to know that the potential cardiac event has been going on for enough time that troponin would actually have time to rise. And so that's why the very first question we ask is, how long has it approximately been since the patient's been having symptoms? These are the symptoms that are listed. You'll all have additional educational stuff to read about the symptoms and the risk factors that we tracked. But it's just three simple to answer questions. And you get to the screen with recommendations. Now, throughout the clinical encounter, this screen kind of updates. You can go back to it as frequently as you want or as infrequently. And when troponin values are made available, they automatically appear to you and automatically update the recommendations. I can't stress enough that no clinical pathway or decision support can replace clinician judgment. So this just provides a way to structure your thinking and perhaps a suggestion for the way that the system as a whole is treating patients if you don't have other information that would inform your clinical care. This is for all the gray area patients where maybe this patient could be admitted, they have some risk factors. Some of the features are more typical of ACS, but then again, they don't have that many risk factors. Maybe their heart scores 3 or 4. I'm not really sure. A tool like this will help you kind of put the patients in a category and inform your decision making. And so some of this is just on high sensitivity. There are additional other modules that we can add on over time, including I talked to Dr. Navati about potentially some risk stratification for atrial fibrillation and some other indications. And all the information from the application is gathered together so administrators can see, is it working? And do we need to change the pathway? Moses Cohen's pathway actually includes a selection for a subset of patients who are very low risk, who, because they're so low risk, if their initial troponin value is low enough and their symptoms have been going on for long enough, it's safe to discharge them after only a single troponin. And that's something that's, I think, going to really enable you to reduce your overall length of stay, reduce unnecessary medical costs while maintaining the highest standard of care and not missing any patients who need to be admitted for additional testing. So I've been working with health systems across the country on this, and this is something that everyone is trying to figure out at once. There's a lot of different approaches. But I just want to really say, truly, working with your team at Moses Cohen, I've seen more cooperation, interdisciplinary cooperation between the IT staff, the cardiology, the emergency department, than I've seen pretty much anywhere else. You guys are doing a really great job of talking to each other and really caring about each other's perspectives, in my opinion, from the places I've talked to. So it seems like you have a really amazing, really functional system here. And I'm really proud of you guys. I'm excited to deploy this new tool with you. And as we release it, I hope that you'll reach out to us or administrators and let us know what's working for you and what's not. The beauty of the tool is we're able to change it over time, modify it, and help it really work for you guys. So that's my
Will this be rolled out the same way?
Yeah, that's a great question. So the way that your administration has elected to do this is this tool will become available to you with a pathway based on the conventional or contemporary assay very soon. So it'll be available to you to go and try and with your current troponin testing. And it will provide recommendations and it will work in almost the same way, just with the current troponin testing is. And then in a few months, I think you were saying March 26th, if I'm not mistaken, when the new troponin test comes along, everything will work just the same way, just the recommendations will change slightly, and you'll have that opportunity for the single troponin rollout. That's the kind of the biggest change in the practice pattern. Yeah, great question. Any other questions on POTS? Okay, great. Well, and if you have any questions in the future, please reach out to anyone that can get in touch with our team and try to get this answered for you.
Thank you, Dr. Gilmore. We do collaborate well together. I just don't know anyone's name. That's the problem. I apologize. Sorry about that. In fact, on that note, I'm going to pull up the chest pain protocol here. Let's see if I can get this going. And it's pretty small. I don't know if everybody can read this, but let me just walk you through this protocol, okay? Just briefly. And by the way, this protocol is evolving, like literally as we speak. There have been changes that have been made over the last several days, so it may not be exactly this protocol, but but this is where we are right now. So, what's that? No, hopefully not, but it could. So, our chest pain algorithm for HS troponin. So EKG, basically if it's a STEMI, boom, straight down to the STEMI protocol. That's easy, that's simple. If it's an ischemic EKG, large ST segment changes, depression, whatnot, we go down to cardiology consult, hospitalist admission in those settings, just like we do now. No changes there. If it's a non-ischemic EKG, this is where we were just talking about the initial troponin result. If it is less than 4, if that initial troponin is less than 4, we go all the way to the right there, and the pain is greater than 3 hours, and their heart pathway score is 0 to 3, then that patient, basically, we bring them down to the consider discharge directly from the emergency room in that setting. Okay? And by consider discharge, this is a patient that does not need cardiology follow-up. This is a patient that does not need a stress test. This patient does not need imaging. And this is a person that, of course, does need, risk factor prevention and those types of things. But the great thing about this tool is that this is where it's super beneficial. It's going to say, hey, you have the liberty or the justice to be able to discharge that patient. That's chest pain for 4 hours, less than 4 troponin. We can consider go home if they're low risk enough. And that's a little bit of a departure to what we do nowadays. If the troponin is in the, let's say, 4 to 99 range, 4 to 99, which is the middle box there, we do a serial troponin at that time. If any of those values are greater than 100 after the serial troponin, or if delta is greater than 20. Remember I was saying how the delta for 0 and 2 hours is very sensitive. If the delta is greater than 20 at any point in that, that's where it goes down to cardiology consult and hospitalist admission. And then in the middle box there, any value between 15 and 99, or a delta between 5 and 19. Okay, so less than 20 basically. Between 5 and less than 20 would be an observation, which is very similar to what we do now. Observation with the hospitalist, and we decide what type of further testing may be needed for that patient. If both the values are less than 18, that's that 99% cutoff again, less than 18, and the delta is less than 5, if they have a very low heart score again of 0 to 3, consider discharge, no further imaging. If it's between 4 and 6, so a moderate patient, we would observe them versus potentially a close follow-up for that patient, okay? Once again, that's a less than 18 troponin and a delta that's less than 5 at 0 and 2 hours. And then if they're a higher risk patient, greater than 7, usually those patients will go down the observation pathway and potentially get further testing down the road. So this is just how the empathic pathway, basically after answering the questions, will basically help us pull in the troponins, place a hard score on that patient, and then help give us some diagnostic or some suggestions on where to go from there, basically. Once again, this doesn't tell you have to do that on any of these patients. This is just a guide for all of us, and there's always going to be times when our clinical judgment would say otherwise. Okay? So what I thought I'd do is just give maybe a couple of clinical examples, just to show how this might work. So clinical example number 1. It's a 35-year-old with hypertension, sharp, right-sided chest pain lasting 5 hours duration. The EKG is normal, and the high sensory troponin at time 0 is less than 4. Okay? So think about that table that we just looked at. Over there on the right, this person has a low heart score of 0 to 3. Their HS troponin is less than 4. They've had pain for greater than 3 hours, very atypical pain. This patient can be discharged from the ER with no outpatient follow-up, with outpatient follow-up and no further cardiac imaging necessary, with a MACE of less than 1%. So a confident discharge for that low-risk chest pain patient.
Can I emphasize, we won't be able to accommodate seeing those patients.
That's primary care follow-up,
That's
not
primary care
cardiology.
Those patients are so low risk.
Right. Yeah, so hopefully that would be a primary care follow-up for risk factor modification, blood pressure control, lipids, and whatnot. So number 2 example, 40-year-old male, sharp, right-sided chest pain, began about an hour before he arrived in the emergency room. EKG, unremarkable. Remember, if the EKG is ischemic at all, we go straight down to the observation pathway, basically, in cardiology consult with hospital submission. But this EKG is normal, and the troponin at time 0 was 10, and at time 2 was 14. Okay? So here on the right, the troponin is less than 18, so that's that 99th percentile cutoff. The delta was less than 5 in this low-risk patient, heart score less than, from 0 to 3. And this would be another patient be okay to discharge with no further cardiac imaging. And once again, the MACE would be 1% over 30 days. Here's a clinical example with a 76-year-old AFib, RVR, about 7 days post-op hernia repair, sent from the surgical outpatient follow-up clinic to the ER, not having any chest discomfort. EKG shows no ischemic changes. He's rate controlled with diltiazem, and the initial troponin draw was 25. Okay, the subsequent 2-hour draw was 26. So a very flat, a very low level delta. Okay, so this is a patient. First off, we have a very low suspicion for ACS in this person. There's no ischemic history here. The delta definitely was less than 20. And this would be a guy that you would probably document myocardial injury or perhaps demand ischemia secondary to tachyarrhythmia. Okay? And this would be a great example where it's important to document this either as demand or injury secondary to tachyarrhythmia, because in this mild troponin elevation, if this AFib patient were labeled as a non-STEMI, first off, the DRG is going to be changed to myocardial infarction from AFib, now as an MI patient. And this would be classified as a post-op MI, which, that has several ramifications for not only the surgeon, but for the institution and whatnot. Here's another example. A 60-year-old woman, no history of CAD in the ERs, with left-sided chest pain, no radiation, resolved in the ER spontaneously, has hypertension, hyperlipidemia, EKG is normal, and the troponin at time 0 was 12, and at time 2 was 16. So what's next? Have we ruled out non-STEMI in this patient with a troponin of 16? So the answer is yes. Non-STEMI has been ruled out based upon the 0 and 2 hour protocol in conjunction with the heart pathway. Her score, if you plugged in all those variables, is a score of 2, and she can be DC'd from the ER, no further testing. It's kind of amazing when the protocol is utilized, and it'll help us make these decisions and hopefully be able to safely allow this person to go home. Now, other life-threatening causes of chest pain. Of course, we have to make sure that we're not missing those, whether that's dissection or PE, tension pneumothorax. We always have to consider these in the back of our heads, as we always do, whenever we make these clinical decisions to send someone home. Here's an example, a 75-year-old man with CAD, hypertension, diabetes, 1 hour of left-sided chest pain with radiation to the jaw. His EKG showed diffuse 1 millimeter ST depression, and his initial troponin, high sensitivity troponin, is 140. What's next? So this person is a non-ST elevation MI based upon the troponin greater than 100 and a high pretest probability or suspicion for ACS. You don't technically need a further troponin assay in this situation. You've already made the diagnosis. The illustration of this is the benefit of the high sensitivity troponin achieving a higher level at a faster pace. In other words, this man just had 1 hour of chest discomfort, came to the ER, and it was already 140. Okay, versus in the old assay, that person, it may have may have required 4 hours or 6 hour troponin before that became positive. So we quickly made that diagnosis, and we can proceed with early invasive strategy for this patient. And this is a 66-year-old with no prior CAD, presents with left-sided sharp chest pain, no radiation, resolved in the ER, has hypertension, high lipids, EKG is normal, troponin is 30 on admit. 2 hours later, it's 45. So the delta there is 15. And her heart score is low, it's 3. Her troponin is between 18 and 99, sort of in this middle box. And her delta troponin is less than 20. Okay, so this would be a person that observation with a cardiology consult with probable imaging would be recommended. And one of the things here is just to note that even with a high sensitivity troponin of 45, this may not be a non-STEMI. I mean, it could evolve to that, but not originally. That should not be the original diagnosis there. So those were just 6 sort of random clinical examples I just want to illustrate with you guys on maybe the value of this this new assay, and that's all that I have right now for y'all. I certainly want to open this up to questions, comments. Oh, and one other thing too is I mentioned that we're evolving, ever evolving in this process, and things will change, things will evolve, whether it's with the chest pain protocol. As we become more advanced with this. And then one of the nice things about this group is that after we initiate, after we switch on the HS troponins, maybe a month or 2 after that, we're going to meet again and we're going to try to sort of brainstorm and solve what went well, what went poorly, where can we improve. So it's going to be an ongoing effort. It's not that we're just going to turn this assay on and then say goodbye and good night. Because I think there's going to be a lot of concern, a lot of questions at first. But we really appreciate everybody coming out tonight and listening to this. Thank you so much.
Questions? Jake has a question.
So having suffered through 6 seasons of the Gilmore Girls, my God, never forget. I'm sorry. Let me ask you guys a question. Would you order a high sensitivity troponin and somebody comes in with AFib and a heart rate of 125 when they don't have chest pain or resting cycle changes?
I feel like it's a somewhat loaded question. But yeah, that's a valid concern. I mean, in that patient, it's highly likely that they'll have some demand ischemia. And if you order that troponin, it's going to be elevated. Again, I don't want to discourage anyone from ordering a troponin if they think it's going to be clinically relevant to their workup. But if you're not having any chest pain, it really depends on the patient in front of you. But I think the point that you're trying to make is that not every patient who presents with any underlying cardiac disease or certainly patients who are having any symptoms of ACS don't necessarily need troponin. Now, I would say that if that patient's,
Yeah, so I think, the emergency department the game is way different than cardiology. So, when I was a resident and I used to be a resident, we play defense, inpatient team plays offense. Our job is to rule out badness. Your job is to then say, yep, this actually is badness, rule in, we're going to take care of it. So, I think the answer is not as simple as you're making it, and where the question is proposed. AFib, new onset, one of the causes is ischemia. If appropriate, troponin should be ordered. I think troponin should not be looked at as a dimer. I think troponin should be looked at as a lactic acid. There are several reasons for lactate to be elevated. There will be several reasons for troponin to be elevated. We just need to know what the clinical picture is and what our pretest probability is for different diagnoses. And say, this is not ACS. I think it's easy. If our lactates come back at 8 or 9 on trauma patients, trust us, we do not get flustered at all. We monitor those patients. They don't even go to ICU. Many of them get discharged. Say that this troponins will be elevated. I think what the inpatient team many times don't see is the number of times we are not consulted on patients that are being discharged. And so I think I trust our guys. I think as long as they have the right information in front of us, they will order troponin, which retrospectively might look like it was not required, but I think the resource utilization will be there.
And remember this order set scrubbing. We have taken, I believe, out of the ED triage order set right now has a point of care troponin where a person can come on in and without seeing either the APP or the MD, they can get that troponin drawn. That is going to be eliminated, okay? Which, I mean, for better or for worse, let's just say, hopefully that will help reduce, if you will, the number of troponins that are being ordered, just kind of a shotgun approach. But like we were saying, I think we just need to be thoughtful about this. With these new high sensitivity troponins, definitely, we're going to see a lot more positives.
I would just wonder in that same situation with the rapid AFib, what the delta would look like. If someone did go on to move to order one and say it was elevated, I would suspect, now I don't know if anyone else has experience with it, please let me know, but my hope is that it would not have the delta of 20 or whatever that would warrant any additional workup. Now, I don't know that for sure. Do you know if Dr. Staines?
I don't know the specific deltas that would occur in that situation. I can tell you with the current troponin assay, I mean, we do sometimes see an increase with tachyarrhythmias over our 3-6 hour protocol. So it would be fathomable to think that the delta could be 20 in that setting. I think, once again, yes, ACS could be a reason for new onset AFib. However, I think that ACS patient is going to be unmistakable. We're going to know that it's going to be that, say, right coronary artery that's triggering the atrial fibrillation, hopefully, in that clinical suspicion. In other words, a guy that's just coming in post-op with a fever and has AFib,
our minds don't go directly to ACS. It's usually another reason. ACS should be sort of hitting you in the face in those situations. So. Okay. Yes.
So one thing you guys talked about is the fact that it's going to be carried out in consult with inpatient admission and stuff like that. One thing I don't see here are even hospitals. So in other words, are the hospitalists signing off on these admissions? Is cardiology going to be the one interfacing with the hospitalist?
Yes to both. So we do have hospitalists that are embedded in this team, this work group. Yeah, I mean, that's all, just like it is now, it's definitely going to be a work in progress. I would say that on our inpatient team, for instance, we are probably the admitting provider on maybe 15% of our patients at this point. So heavily consulted, and even with certainly all of our STEMIs go directly to cardiology. A fair number of our non-STEMIs come to cardiology, but that doesn't mean that all non-STEMIs need to come to cardiology or all those types of admissions. And then our hospitalist group, as they continue to grow and expand, hopefully we'll be able to handle those loads. Yeah, Dalton.
Mark, what kind of education, in the hospitals? What I would fear is really cardiology getting small, the middle range, 18 to 99, and going to 5 to 19 range. And it's getting small consults for that.
Yeah, that certainly could happen. So he's saying, we're worried about getting swamped with all these like 75 troponin consults. And remember, if we move the decimal spot over, what would that be? That would be like the 0.07 to 0.08. So abnormal, slightly abnormal, and they would literally be falling into probably our 5C chest pain units to begin with, those patients. But as far as the education goes, yes, we're going to be getting out in front of the hospitalist groups and doing this type of thing with them as well. And all this educational material we supply to them. And it's going to be a growing process, Dalton. I really think. I mean, it's not going to be. I do fear that there will be an uptick in our battery discharge from our iPhones, certainly in that first week. And as we begin to learn and evolve, we'll become more comfortable with it. Is the hope. And maybe even like, I don't know, I hate to put Dr. Christopher on the spot. I mentioned her earlier. One of our new colleagues, if y'all haven't met her yet, she's unbelievable. So maybe can you comment?
Yeah. So anybody I haven't met yet, I'm Bridget Christopher. I've been here about 6 months. Did my cardiology fellowship over at Duke and met you all by moonlighting. So I am very familiar with the ER admission process, even before coming here. So I think this is fantastic. And there's going to be growing pains. There were growing pains. So what we typically saw, the way Duke functions, is there's a clinical evaluation unit attached to the ER. And we would have many patients get admitted there, monitor troponins, and then usually stress echo or nuke before they went home. Those patients almost disappeared, really. They tended to be kind of the lower risk, but you didn't really want to send them home. We weren't sure, and so you do the testing would be negative, and they would go home. So that workload decreased a bunch. I would say the biggest headache early on, CKD, kind of systolic dysfunction, anything, I hate to say this, but until they had come into the ER or been evaluated a couple of times, and people got comfortable knowing this is just their number, and this is where they are, because especially in some of the ESRD patients, they can have significant troponin elevation, and a lot of panic phone calls, kind of the first week, oh my gosh, and after getting comfortable with that and seeing that and realizing that doesn't automatically mean that there's something new, it definitely evened up over time. There were, still some mid-range consults about what do we do with this, and still I think there were some hiccups because our protocol was they don't get stress echo or nuke if they have any elevation of components, and so we had that hurdle of, well, now what do when they're in the middle range? So it did take some time to kind of float out. It was a little tricky in, but I would say really dropping off those very kind of low-risk people at the beginning. Once everybody sort of found their footing with that mid-range, I think it got a lot easier.
Thank you. Appreciate it, Dr. Chris. Yes?
So beyond just the initial diagnostic part, where you had 2 hours and you said you didn't fit for observation. So now we did the troponin Q6 hours thing. What's the follow-up after 2 hours? I mean, you know how we follow the peak sometimes, that's what is there?
Yeah. Well, like I was saying earlier, the getting an added troponin once we've made that diagnosis is not necessarily needed, but it will be just like our troponins do now. In other words, the size of MI.
I guess I mean more, well, not only that one, than that in the ground. You know, is 2 hours sufficient? Or what if what if it's 99, 2 hour point?
Yeah, I mean, that may be a situation where you can always get another troponin 2 hours after that if you want to be certain, but hopefully the protocol, if we're utilizing the protocol correctly, that we should be confident with that algorithm.
So the protocol is 2 times.
Yeah, 2 times, that's it. In the ER, yeah. Now, okay, so once they're on the floor, right, so it may be different once they're on the floor, but I believe I can envision a similar type of 0 and 2 on the floor as well.
So is it not worked out yet?
No, I mean, there's no specific guideline for the inpatient protocols or anything along those lines. I mean, this is for an ED protocol, but just like we do now, we order troponins when we see a patient in the inpatient setting, 0, 3, and 6. I would extrapolate that to doing 0 and 2 and seeing where that delta is and utilizing it that way.
I think our order sets aren't going to change. It's probably still going to be the same interval. Yeah. That's what I'm asking. That's a big change.
We can talk about it. We talk about it.
Yeah.
Yeah, right now, the plan had been to change all the order specs to a 0 and 2 from initial testing. I think after the second test, whether they've been admitted or they're already an inpatient with a new development and you're doing 0 and 2, that third test will be the discretion of the cardiologist to see the patient and whether or not
It's not the speed at which you diagnose that. It's the missing part that was the important 0 and 2. The speed at which it changes it on the floor is not so critically important. Any different than 6 hours.
And I thought maybe we were going to get to the point of what if it's decreasing? And that's another point that we really didn't talk about here is the negative delta. You know, we have to be cognizant of that too. Somebody could come in after a day of chest pain and have a troponin of 250, and then the next one might be 248 or whatever, 230. It's on the tail end of perhaps an MI, so we have to be wary of that as well.
So Mark, this assay, is it that the half-life is as long as the current troponin, meaning that if it's high, does it stay up for a week?
I know that it will stay up like our current troponins do. That I don't know if maybe our lab.
From what I've gathered is that it does have a half-life that is not, I'm sorry, it does have similar to the troponin, but the current troponin that is not as long. So therefore, it levels off, you know, once they become more stable. That's what I was able to gather. What if you have ischemic GEs going on with these
So the question is like, what if we have chronic ischemic changes for 10 years and they come in and their troponin is borderline? I mean that's going to be a good illustration of where our clinical judgment will definitely have to come into play, right? I think I would treat that as I treat that today, where I know that that patient has an abnormal EKG at baseline. Their troponins are about what they were at their last admission, and look at them clinically and make a decision based upon that, just like we do today. Yeah.
So the current troponin gonna, so someone say stage 3 chronic kidney disease, it's gonna throw them, is it gonna be more likely to throw them into the kind of that middle range of troponin?
At least, I would think, I mean, if I had to find a guess, I would say that definitely, if it's at borderline, it's kind of like what you guys have to determine. It's like with the first generation troponin, not the third generation that we're using now, we had, especially for the order physicians, you remember the gray zone that we had. It's kind of like until you guys get familiar with what is clinically significant or not, that 18 to 99 is going to be kind of a gray zone that you have to determine based off the clinical picture if it's going to be, if it's significant or not. But the numbers are probably going to be higher. And it's going to be probably more than what you've seen with the old. But you just got to take that in consideration with how the clinical picture is.
And I would envision that on these chronic kidney disease patients, it's going to take a couple visits for them to understand that 350 troponin is the same as it was before, is the same as it was before. I think it's just like we have the assay now. But remember that 3 decimal point rule, we still have access to the troponin I of old, and we'll be able to look and say, oh, they were, 0.1 all the time. So if they come in with a troponin of 100 at the next visit, then that's approximately what they were. And I mean, if they're not having any ischemic symptoms or no chest pain, well then, first off, why was the troponin ordered? Think about that. But if they were having chest pain, then you could say comparatively, it's about where it was previously. But you're still going to see this. And to that MI point, the demand point, Dalton, like your service, for instance, acute systolic heart failure, how many positive troponins do you have on 3Ds? Like almost everybody, right? Like as of right now. So you certainly will have almost everybody a positive troponin with the high sensitivity. And if we label those the supply-demand mismatch because of systolic heart failure, if we label them type 2 MIs as part of the definition, every single one of Dalton's patients would no longer have acute systolic heart failure as their #1 DRG. It would change to acute MI. Every single person on the floor. It's ridiculous. As of right now, that may change as the DRG systems evolve and whatnot to become more sophisticated, but that's not what we want to see, I think, happen as an institution.
So can we clarify something up there? We had a lot of discussion in these meetings about conjunctions and in 4. And it says cardiology consult and hospitalist clinician. This goes to Tony's point. I think it's the same if you know that it's an acute coronary syndrome and they're not septic, it's been hemoglobin 6, call it. I personally feel very strongly about this. If you've made the decision that they can go to the hospitals for observation, the hospital should see the patient, admit the patient, and call us after they have seen the patient and if they need a cardiology consult. I don't think you guys should be in the middle of that at all. I think it's rare that you should be calling before we should make a consult exactly at the same time. And I'm happy to continue to take up that fight with hospitalists. And I've never been in a program where they're asking consultants to come see the patient before they've seen the patient. If you guys have made a determination that they're appropriate for the hospital service. So that, in the end, is a little misleading up there.
We'll take it. So,
That's a great point. Now, one question would be for patients with known coronary artery disease. So this algorithm is for patients who are low risk and coming in with undifferentiated chest pain. So what do you do for patients who have known coronary artery disease? Heart score, everything is out the window at that time. So the current system is we will assess them. If ACS is still in the differential, then those patients are getting admitted. And cardiology is consulted often. Do you still want those patients that have known coronary artery disease coming in with non-specific chest pain to be consulted or not? I think that's something that we'll have to figure out. This algorithm is not addressed. No one's even.
Actually, as I spoke to Dr. Gilman, just if I could, totally correct me if I'm wrong, the studies for our pathway initially did include known CAD, but it was just for just practical reasons that they were plucked out, so this data is good for known CAD.
Yes, Shannon, that's absolutely right. So the heart pathway
one kid, no CAE patient, let's just say, prior stent placement comes in with chest discomfort and the troponins are, 14 and 16, so below the 99 percentile. Well, I think this is an area where obviously we can use our clinical judgment, number one, and certainly if the phone call comes to cardiology for us to review that case, I think that's totally within the limits. That makes good sense. But third, something we didn't allude to here is, well, what if that patient just had a nuclear stress test done 6 months ago and it was normal or low risk? I think that would, with that information, with some sort of added imaging information, or a recent cath, for instance, less than 3 years ago, with a non-ischemic EKG, I think that's where we use our clinical judgment and say it's okay for that guy to go home in that situation. So.
Okay, Mark, is there data about the level of post-PCI patients?
High sensitivity troponin.
Because the traditional troponin is that peak on the upper limit, if normal, is considered okay. Anything above that, that's post PCI in mind. So is that, do you have an idea?
Yeah, I haven't seen any data pertaining to that, but just like our ultratroponin greater than 3 times upper limit, we will see this as well. And we're not recommending that we check HS troponin post PCI unless there's a reason, right?
Right, so we don't do it routinely, but sometimes they get some chest pain, and we're thinking it's not related to the PCI.
Right.
We have to determine if it's totally valid or not.
So I think we have to just be analogous to what we have right now, greater than 3 or greater than 5.
There's a bunch of stuff. That's a great question. And clearance, we still don't know the alert that we have to call the let's call it. So we have
First of all, how long does it take to run in the lab? With Vizient, our lab is like overburdened and we're waiting a long time. Like the other day, I waited like almost 2 hours to get a CMT done because now we don't have ISATs anymore. So like it's possible to get 0 to 2 hours and actually get the test.
Well,
Or we have to order another one.
The impact of the ISAT, let's kind of break it down. We've added about 25 to 2,700 more tests. It's not only the lab, it's the order time, it's the collect time, it's the send time, it's the receive time. The one thing about this that'll make it a little bit better is we're double spinning because the current troponin is sensitive to red cells. So if you have any red, that's why sometimes you may have seen a false positive. It's not necessarily that anybody did anything wrong, it's just it's more sensitive to red cells. So what we're doing is spending only 10 minutes and then ultra spinning it to try to give you the best results we can. The assay is about 4 minutes longer than the current. It's 17 minutes versus 13 minutes. So if we can reduce the spin time, it's still going to be fast. It's going to be about the same, if not a little bit faster. Now, it's like anything else. When you have everything stacked, it's going to be hard because now we're looking at the BMPs, the lactic acids, because you're having those things. We're doing validation studies for using certain things for a faster centrifuge to get it on with a process you can't just start it. So to answer your question, we are looking at ways of trying to change the way we're doing our specimen processing to receive it in and get it spinning faster. There's a lot of variables, and I've worked with a lot of people in the ED. Sometimes it's us, sometimes it's not, but we're trying to get the process good so it's good for all you guys. And so that's why we're looking at potentially trying to get more staff, changing the way we do things to make it more efficient, and that's what we're looking at now. So you're going to always have isolated cases where it took longer, but when you look at the vast majority of them, over 90% of them are done within an hour. But you're going to have that 1 or 2 every now and again that's not going to be correct. And sometimes it's instrument issues, sometimes it's not spun, it took too long to take it out of the centrifuge. Sometimes there are a lot of variables that's why I like to have a lot of the docs that I've talked to deal with a lot come down and let me show you what the process is, what the barriers are, why there's issues. So once that you have understanding that it's like sometimes there's only one person for the entire hospital. So to answer this point, We are working on it, trying to get it better. The vast majority of the time, you're probably not gonna have issues, but you are gonna have some issues. I mean, I'm not gonna sit here and lie and say you won't. But our goal is to try to limit that as much as possible. No, sir.
So my second question was, you changed the troponin to be 18, but like the article that you gave out said for women, it should be 50. So like when we're getting troponin levels of 16 or 17, is there like any type of like risk for women who are following that category without doing a second one when they follow this category, but based on the paper, they should be counted as positive?
That's a great question, and the answer to that is the backup. Our backup is the delta. Our backup is the delta. So if the delta, say a woman comes in at 17 and her delta is 20, obviously now that's legitimate change. If her delta is less than less than 5 on that, in that situation. So maybe it goes from 16 to 19. So in that grade, that's going to be more of an observation patient, just based upon the heart score. Obviously, if they're a high heart score, maybe you need further imaging. But that's a really good question. And it was thoughtful to avoid the sex-specific protocols only because, we felt like it was going to lead to a lot of confusion if there's 2 separate troponins that are being valued in the lab system and which one is what. And there are other institutions like University of Florida, I believe, which you guys have worked with, that are going to gender-neutral troponins there to help with the to minimize confusion. That's a great question. So the delta hopefully will be that buffer to help alleviate that problem.
So to piggyback on what you're saying, the act, what you're saying is 100% correct. The minimum of 5 to 15, the minimum of 5 to 20, like we have the sex specific, but it's going to be in that neighborhood range that you were just saying, between that 15 to 18, where like you were saying, if you do the secondary, you do the second one. If it changes, like I said, based off the clinical picture, it is a little bit different. So that's what we learned. That's what we learned today in terms of, just trying to make it easier for the physicians. But you're 100% right. The way it was validated for Beckman, they did have sex.
Questions?
So thank you guys for organizing this, and I think that there's a lot of opportunities here outside of just simply the change in the laboratory value. I think the conversation back and forth between emergency medicine and cardiology and creating some standards, and I think the take home that I'm getting from this is we need to hone in on the actual symptomatology and diagnostic, like we did with the D9er, and order this appropriately to Jake's point earlier. We may not need to every AFib RVR patient who is not having symptoms of ischemia order because we're going to find a lot more positive. So I think this is an opportunity for us to kind of hone down, to get rid of a lot of those troponins that we have that are getting ordered by protocol, and to get a little more focused on our diagnosis, and then we hopefully will cut down not only on the appropriate patients, but maybe on all those extreme issues.
Thank you. That was really well put. And it brought to mind, like, for instance, our syncope order set had troponin embedded within it. It was never checked, but it did have it there. And you can imagine that any provider that's working on syncope and utilizing the order set, like a good steward of the order set, and goes down and maybe sees echo and EKG and EMED in the morning, and then all of a sudden there's a troponin there. And they go, well, yeah, let me check that because obviously that's better for the patients. Make sure they don't have a heart attack. Well, syncope in the setting of ACS, once again, it should be pretty apparent that the person's having an issue, hopefully, okay? And for AFib, we took it out of the AFib order
set for that same reason. It's not part of the workup for atrial fibrillation unless we're worried about it.
So I want to thank Jay for what he said about trying to engage your hospice colleagues. I hope that when you speak to them, you also kind of relate Jay's sentiments. But, one of the other things I struggle with is that there will be more cardiac, there will be more consultations from you guys or with the need. And right now, there's a little bit of a delay in trying to get that. So is it going to be a change to the process and how you guys do your consults so that our patients, so that our group is successful?
Yeah, so, no, that's a good question because there's some, yeah. 2 new cardiologists coming soon to the podium. But yeah, from a process point of view, this is going to expose a lot of different things, and we all struggle with access, whether it's in the outpatient setting or in this matter, in the inpatient setting for consultative reasons. So I think by initiating this, it's going to allow us to really look at our approach to seeing these patients in the ER and trying to figure out ways to get down there quicker, get a disposition faster for you guys. Without a doubt, I think it's going to help expose a lot of those areas. But hopefully, maybe to Dr. Christopher's point is maybe a lot of the lower risk chest pains, or according to the journal we just reviewed, a lot of those guys will be going home and may not, we won't be asking for the consult. And sort of the pessimistic view of me right now is that, if we're not spending a lot of time consulting on the 85-year-old with sepsis and the elevated troponin, if hopefully this message can get out there that, hey, we don't need to order that on that patient, then we can focus on those that you guys really need us to see in the ER, because we spend a lot of time now on elevated troponin consults in the inpatient setting, for better or for worse.
So you guys have done a brilliant job with it. Maybe as a model of how things should happen. And I have no doubt that this is going to lead to that kind of improvement in you guys handling these things. And I also think this conversation then leads to us having further conversations with the hospitalists about true observation protocols and who gets CT scanned and who's geared up to be able to be present in the middle of the night. Just lots of opportunity here to bring us back to a rational decision on where this test was released. And then the interpretation we can work on together and the protocol we can streamline. And I think AFib is a perfect example of how I go around nationally and people ask us all the time about you shock people when you understand well. For example, what you were talking about, I think you're right. I think, this is a great place to work. And I think this kind of opportunity is coming.
I'll tag along with the word opportunity. So with the platform, we will have the ability to collect a lot of data, and we will be able to refine the protocol further. And based on that, we will be able to refine our decision making as well. So that's the hope. So there will be some projects that will jump from this. THN has promised to partner with us further. The guys from Contact are very excited to partner with us. So there will be some very important results that we'll get from this. You can clearly see the heart score. I think some of the cardiologists probably would appreciate it. So less than 3 or less than 4, I should say. It's a key cutoff because we know the MACE is less than 1% for those patients if the delta strokes are negative. So that 4 to 6, that number jumps up to 10 to 18%. And there's no crystal ball in knowing that who that 1 out of 10 person is going to drop dead potentially. So, and then when that goes up to what's the next, or 6, it's like 60% MACE or higher. So these cores, these decision-making tools are very important, and I think that 4 to 6 will be a big opportunity to send even more patients home. None of these patients right now are going home. If their heart score is over 4, and we are thinking ACS as reasonable in our diagnosis, we are keeping them because we
but the heterophile antibody, the false positive that you were saying, was greatly reduced. So we've actually had a case where a patient was coming into Med Center High Point, and the doctor knew that they had heterophile antibodies because they kept getting these false positive troponins. They sent them and he ran them on just to see how it would work, and it was negative like it was supposed to be. So while you can't say that heterophile antibodies won't definitely affect this assay, it's significantly lower. So the false positive rate that you can see, that wasn't any error, that wasn't red cell driven, that was heterophile antibody driven, it does seem like it's less. Now, you have to gather more data, but that's what it's looking like now, that it is really a much more sensitive assay